And it's my pleasure to present Dr. Niloufar Salehi. He's an assistant professor at the School of Information at UC Berkeley and a faculty member of BayLearn, the Berkeley AI Research. She studies human-computer interaction with her research spanning education to healthcare to restorative justice. Her research interests are in social computing, human-centered AI, and more broadly, human-computer interaction. Her work has been published and received awards in premier venues, including ACM, CHI, CSCW, and has been covered in VentureBeat, Wired, and The Guardian. She's a WT Grant Foundation scholar, and like many people here, apparently, she has received her PhD in computer science from Stanford University. So let's welcome Dr. Salehi.
Thank you so much for the kind introduction, and thank you for having me here. I hope everyone's had a chance to have their afternoon coffee. And thank you for the hosts for organizing this event. So if you're anything like me, you've spent a lot of the past time thinking about how are users expected to rely on these models that are failing in unpredictable ways. And over the past decade, I've been studying how do we design computational systems that meet user needs without causing harm. So over the next half an hour, I'm going to walk you through why designing reliable AI systems is important, why it's hard, and how our research is trying to solve for that problem by centering the human that will be using the system. But I'm going to give you a little background first. So when I was in grad school, I read a book that really sparked my interest in thinking about and understanding human behavior and studying human-computer interaction. And that book was this book called Predictably Irrational by Dan Ariely. What this book does is it looks at the complexities of human behavior that most of the time don't really follow a rational actor model that we would expect, but still follow certain patterns that make them overall predictable. And more recently, I've been thinking about how machine learning models are sort of the opposite of that. I'm calling them unpredictably rational. So a lot of the times, especially when they've seen similar things in their past data, they seem to act rationally, but their performance is unpredictable. And that's what makes it really, really hard for us and our human brains to figure out what to do with them. And this is one of the big challenges in human-centered AI, is that we need to basically design systems for ways for people that are predictably irrational to interact with models that are unpredictably rational. So let's start with an example. Imagine that you're a doctor, and you have a patient come in, you've just looked at their lab results, and you want to tell them to hold their kidney medicine until they've had a chance to speak to their kidney doctor. The challenge is that you only speak English and your patient only speaks Mandarin. So you put it through Google Translate and you get this text back. Now imagining that you don't speak Mandarin, assuming you don't, would you give this text to the patient? Let's do a show of hands. Who would hand this Google translation to the patient? Okay, so this is only about 2 people raised their hands. I'm not surprised, though, because whenever I give this example to a technical audience, that's the response. It's like, no way. But I would like to share with you that we've done research, and across, especially in clinical settings where a lot of people don't speak English, physicians, clinicians, nurses are almost using Google Translate all the time to communicate with patients who don't speak English. From an HCI standpoint, so if you said no, you were right on this one example. In this example, the Google Translate outcome translates from hold the kidney medicine, so stop taking the kidney medicine, to flipping the meaning completely to keep taking the kidney medicine until you've had a chance to talk to your doctor. This is an example from a real data set that my collaborator at UCSF Hospital ran, Elaine Kung. She took a data set of commonly used discharge instructions, ran them through Google Translate, and then found a bunch of errors, including some that were potentially life-threatening, like this one. And from an HCI standpoint, the problem with this interaction is 2 things. The first is that it's really hard to identify that an error has happened. You have no signal of it. And the second part is that there are no actionable strategies to recover from the error. So even if you knew that there's an error, what are you supposed to do with it? Let's look at another example. Imagine that you're summoned to jury duty, and you were not able to get out of it, so you're there. And you're presented with this evidence. And this is similar to what you might actually be presented to as a jury. I'm going to give you a minute to read over it. Okay, so this is from a case in 2018. Let's do another show of hands. Who thinks that this is reliable enough to convict the defendant? Okay, so no one raised their hand this time. This person was actually convicted in this case. This is a case that was reported in ProPublica, New York Times. It's a real case where the person's lawyer later appealed and was acquitted, partly because of the reliability of this DNA evidence. My point in these examples is that it's really important for these models to be reliable. So in some cases, it's a life or death situation, and also that it's really, really hard. So I'm going to share 3 projects that my lab has been working on around thinking about this issue of reliability. The first one that I'm going to share is about how do we help users craft good inputs to models. The second one is how do we help them actually evaluate model outcomes. And the third one is how do we involve users in the synthesis work that these models can do. So I'll start with the first one. This is work that we did in collaboration with faculty at UCSF Hospital through a program at Berkeley called Computational Precision Health. And our work found that when we were looking at machine translation in these kind of healthcare communication contexts, that the models were good at some things and some ranges of inputs and really bad at other ones. And a good signal of that is it close to something that they've seen before? And so our motivation here was, is it possible to actually guide users towards the kinds of inputs that the model is good at? So first I'll describe the context here. We started looking at text-based communication. So usually when someone goes to the hospital in the US, you're legally required to have an interpreter if you don't speak English. But a lot of the times the discharge instructions that you get sent home with is actually all in English. And so machine translation has the potential to massively improve communication across these text-based barriers. The problem is that, like I showed in the example at the beginning, it doesn't always work. So that paper by our collaborator, Lane Kung, found that 8% of sentences from emergency room discharge instructions were incorrectly translated to Chinese using Google Translate in a way that had potential for clinically significant harm. Another paper found much bigger errors, especially for lower resource languages like Farsi and Armenian. And you might be surprised by how big these numbers are. I was. Partly because we're very used to Google Translate being very reliable. But this is an example of what I was saying, that it's unpredictable when it's going to work and when it's not going to work. And these incorrect translations are actually really dangerous. They can lead to, someone taking the wrong medication or long-term consequences. And you might be thinking, well, part of the problem is that these models have just not seen enough data. And I agree with you. I think that seeing more data will improve the accuracy scores. As you can see, it's much worse for languages where we have less data, like Farsi and Armenian. So I agree that the accuracy will be better if it sees more data, but there will always be some errors. And the issue here is that the system doesn't provide any kind of differentiation between, say, translating a menu from English to Spanish with translating medical instructions from English to Farsi. The interface looks exactly the same. And so you're not getting any kind of a signal of, is this a reliable outcome or not? But despite these issues, like I said, our research shows that machine translation is actually used a lot in clinical settings, which has led to some worry in the media and titles like this. So where do we go from here? When we started looking at this problem and collaborating with physicians, one of the things that we found is that hospitals already had a ton of pre-translated material. These were often in the form of discharge instructions for, say, someone who's had a kidney operation, and they were translated to all the different languages. Physicians rarely used these because they were very static, so you couldn't tailor them to your specific patient. It was just pre-translated. But that data existed, so that's one thing we can use. The other thing that we found was that the discharge instructions were incredibly repetitive and very structured. And we thought, is there a way to use this translation memory of data that we already have to make this more reliable? We found that our translation memory can actually provide a good definition of what a good input is that leads to reliable outputs. And that's the basis for our systems to follow, which is a domain-specific translation tool that is interactive. The main idea is retrieval augmentation of models, which a few people have already talked about today. One of the more famous examples of that is a system called Atlas. Here we're looking at a specific type of retrieval augmented model called nearest neighbor machine translation. So what nearest neighbor machine translation does is it increases machine translation performance by using a nearest neighbor classifier over a large data store of cached examples. So imagine that you have this baseline machine translation, and you also have a data store of billions of examples that you can use at the point when you're generating the output. So this is a quick overview of what that looks like. What it does is basically on the bottom, you see the test input and the generated token so far. So we have a vector representation of that. And we have similar vector representations from our data store, so our examples, which we call our index. So we take the top k out of our examples. We take the nearest ones, we do some normalization, and we end up with 2 potential tokens for the next token. One of those coming from our index and one of them coming from our baseline model. And then we take, with some probability, either the index selected token or the model selected token. There's work that shows that doing this, so using this data store of examples, improves a baseline machine translation by an average of 9 blue scores without any additional training. And it's especially good if you're doing domain-specific translation. So if you have a if you're doing law information translation, which is a very specific type of language, and you use a data store of examples, you can increase it by 16 blue scores and 14 blue scores in medical. So we thought, okay, that's really great, because the other thing that this is doing is that this nearest neighbor machine translation is giving us an intuitive definition of what a good input is. And that intuitive definition is that the closer I am to that retrieval index, or the examples that I've seen before, the more likely it is that the translation is going to be accurate. And so our design goal, remember, was how do we guide people towards better inputs? One way to do that is to help users write in a way that is similar to the index. So let's walk through an example. Imagine that you have seen this sentence, you want to translate it. It's please return to the emergency department if you have a headache. And like I said, we have 2 ways to generate tokens. One is from our index, so our examples. The other is from our baseline model. And then we take that and we aggregate it into the next token. So a lot of the times, actually, the token is the same across both models, and we just take that. Sometimes it's different. When it's different, our model has to decide which token to take. So in this instance, it took the index's token. We generate a few more tokens. Again, we have something where it's different. This time it took the model selected token, and we complete the sentence. So you're already seeing that intuitively, we're starting to see how much we're using our index. So that's the first thing that we define as a metric called utilization. And that's the percentage of tokens where our final translation agreed with what the index said we should choose. The second metric is that, you know, the times when we picked from the index, how close was that token to the token that we were going to take? And that gives us an intuitive definition of how close were we to our index when we chose it. So intuitively, index and utilization give us some metric of how good a translation is. And that was verified by our data as well. So here's a little bit of a complex graph, but I'll explain it. We took our sentences from our medical translation domain, and the y-axis here is utilization, the x-axis is index relevance. So the higher up the graph you are, the more you're using your index, the more to the right you are, the closer you are to your index. The size of the dots here is just the number of sentences that fell into each of these, and the color is the average sentence blue score. So one thing that's immediately obvious, there's sort of a correlation between utilization and relevance. And when we're at the lower parts, there's not much that we can say about quality because we're not really using our index. We're mostly falling back on the baseline model. But when you look at the top part of the graph, that's where we are using our index. So that's when the sentence was in topic, basically. There's a significant relationship between how close we are to our index and the sentence quality. So that's what we were looking for, right? An intuitive way to guide someone towards better inputs. And that is move them towards the top right of the graph. And that's what our systems to follow does. So sometimes we have examples that are so close to the sentence that we can actually just use it as a template. And in those cases, we say it's an exact match, and we can actually show to the user, here's the template I used to translate your sentence, and you can just verify it. And other times, we're using fuzzy matching, like the one that I just showed. And so what we do is when the user puts in a translation, we go through the sentences one by one, and we give them some feedback about the potential quality of their translation. So here's what that looks like. You can click on individual sentences. You have some measure of the coverage and the closeness to the index, which we're calling utilization here. You can look at other phrases and what the sentences the model thought were close to this, and we can also offer rephrasing. So if you had a sentence that was far away from the memory, we can offer a way for you to rephrase your sentence so that it's closer. A lot of the times that means taking a really complicated and long sentence and breaking it down into smaller sentences. But the goal here is that the user can actually read and say, yes, this is the same as what I meant to say, but now we have a sentence that we actually can, with higher certainty, translate. So the key design insight here is that one of the things that we're going to need to do as more people are using these models is to guide them towards how to produce good inputs to the models. And one way that we can do that is by relying on existing data stores. So that's Safalo. I talked about how to guide people towards creating good inputs. The second thing I'm going to talk about is how do we help them evaluate outputs. This is again with some collaborators at UCSF and University of Maryland. So remember this interaction where I said the person just sees the output in a language that they probably don't speak, and they have no way of knowing if it's right or not. So one thing we started to think about was, what if we trained an additional model whose job was to say whether the first model was right? You can immediately think that that's probably as hard as training the first model, and it sort of is. But in machine translation, we actually already had models that we can use, and these are called quality estimation models. A quality estimation model for a machine translation system is a quantitative measure of how well it translates. And there are some very commonly used ones that are called reference-based metrics, like BLUE or Meteor. And what these models do is they take a sentence, they take its translation, and they also require a reference translation, so say a translation done by a human being. And then they can compute similarity scores between the translation from the system and the translation, which is the ground truth. The problem here is that to use these models, we actually need reference translations. We need a human being to have translated it. And if we want to build an interactive system, we don't really have that. But there's a great set of more recent models that actually get away with not having a reference translation. An example is Comet. So what it's doing is it's taking multilingual sentence embedding. It's basically taking the source sentence, its translation, turning that into a multilingual vector, and then it's using human-generated rankings of translation quality to learn what is a good translation. So what we can do now is we can give it a sentence, its translation, and it will give us a score of how good this translation is without us needing to have manually translated that. So the question we had was, if we took this quality estimation output and we showed it to physicians, would that make them better at deciding when to rely on the outcome of a translation? There are some challenges. QE models are not designed to be shown to people. They're a number between -1 and 1. And if I tell you, here's a translation and it's 0.3, that doesn't really mean anything to you. So what we did is we took a data set of medical healthcare communication, we translated it, and then we had some bilingual physicians actually go and score it. So we started collecting some data. So the question that we asked them was the quality of the translation. But our physician collaborators didn't care as much about quality as they cared about whether there was potential for significant harm. So we first gathered this quality data. We could use it to create some thresholds. And then we changed our task to, is the sentence accurate or not? And if it's not, is that a mistake that has clinical significance or not? Because that's what the physicians really cared about. So we collected all of these human annotations. It was really, really hard. So despite our physician collaborators being the ones who suggested this, they could not agree with each other over what clinical significance even meant. So we had to do multiple rounds of labeling, setting up meetings where people could talk through it, and we went from very, very low agreement to some measure of reasonable agreement. So we had these two things. where does each sentence lie on quality and where does it lie on clinical significance? And we came up with these 3 thresholds. So depending on the raw QE score, we either told them that the translation is consistent with the source, the translation retains most of the meaning of the source, or the translation preserves only some of the meaning of the source but misses significant parts. So now we took that number and turned it into a sentence that presumably means more. We recruited 65 English-speaking physicians, and we ran a controlled experiment with them where we would show them a discharge instruction taken from our UCSF data, and we would translate that through Google Translate to Chinese. We checked that none of these people actually spoke any Chinese, and the sentences that we picked, we deliberately picked so that they had a range of quality. And we asked them 2 questions for each sentence. The first question is, would you give this translation to a patient who only speaks Chinese? And the second question is, how confident are you in that decision? So we split people randomly into 2 conditions. The first one, we used the quality estimation score that I just described. And the second one, we used what is currently the state of the art, which is back translation. So in our research, we found that a lot of the times physicians would translate and then click that button where you can flip it around and see the English again. And we actually found in one hospital at least where this was provided to physicians as a way to check the translation. So before I show you the results, let's do a little test to see what people think they're going to be. Who thinks that showing physicians the outcome of the quality estimation score will make them better at deciding when to rely on the translation? Okay, very few people. Who thinks that showing them the back translation will make them better at deciding? Okay, more people. So that's what I thought too, going into this. I was pretty sure the QE was just not going to work. But maybe I had done the back translation myself, so I wasn't sure. The outcome measure that we chose is something called confidence-weighted accuracy. It's a commonly used metric in psychology studies. The basic idea is that if you're right, you get 1 point. If you're wrong, you get -1 point. But if you're wrong and you're really confident, that gets weighted by how confident you were in that decision. So that puts together basically whether you were right or not and how confident you were into a single metric. And what we found is that relative to a baseline, when people had the QE model, they were significantly better at detecting when to rely on a translation versus when not to. But in the back translation model, it didn't really matter. So that's great. I was actually kind of excited. I was like, wow, we found a way to help people figure out when to rely on a translation. The basic idea is that you can use sentence embedding, gather user feedback on what is a good quality outcome, and then you basically train a model on that to give an estimation of a quality for a new outcome. And that seems like something that could be applied to a range of tasks. But remember I said that our physician collaborators cared less about quality than they did about significant harm? So we started looking at it. What if we only looked at the sentences that were right or the sentences that were wrong? And there the story is a little different. So if you look at only the sentences that were correct, the QE condition was much better at deciding at relying on it when it's right. And the back translation was actually kind of worse at deciding that it was right. But when it was wrong, it was the exact opposite. So back translation people did not give people sentences that were wrong, much more than in the QE condition where they were actually just giving them the sentence. And this effect was much bigger when we looked at sentences that were wrong and had clinically significant harm. So here's an example of our sentences. These are all sentences that were incorrectly translated and their clinical risk. And so the correct answer here is to not give that sentence to a patient. The column on the right shows what the back translation people did, and the other one shows what the QE people did. So you can already see that the back translation people were better. For instance, in this last one, it's a highly significant error. The back translation people did not give the sentence to the patient 94% of the time, but the QE people didn't 53% of the time. So what this is telling me, or the key takeaway here, is that what is a good intervention in evaluating outputs has a lot to do with what your goal is or what you're trying to do. And when you have multiple goals, you probably need multiple interventions. The key design insight is that we can develop models, quality estimation models, for instance, that can help users decide when to rely on an output, so when the output is correct. But we will likely need a range of interventions for different kinds of errors or different kinds of modalities. So I talked about helping people create good inputs. I talked about helping them evaluate outputs. The last thing I'm going to talk about is more of a teaser of our more recent work, where we're thinking about user-guided synthesis. And this is work with collaborators at USC and Berkeley. The core idea of the system that we're calling Yodi is how can we augment large language models with knowledge graphs? So the strength of large language models, which a lot of people have talked about today, is their generalizability and language processing capabilities. But they're also criticized a lot, right? As a lot of you know and have spoken about, in producing factual knowledge, interpretability, and domain-specific adaptation. So there's a lot of interest these days in what are ways that we can actually integrate knowledge graphs with large language models. Knowledge graphs provide an accurate and explicit form of information that you can look at and see what it is, and you can update it if needed, correct it if it's wrong. And knowledge graphs can therefore enhance large language models by acting as an external source of information. The challenge with knowledge graphs, as I'm sure a lot of you are aware, is that they're very difficult to create and maintain. And so there's been some interest recently in how can we use language models in developing knowledge graphs? And how can we build synergized large language models and knowledge graph systems that enhance each other mutually? So think of the LLM as providing knowledge representation and synthesis, and the knowledge graph as providing factual information in a structured way. But there are dangers to the synergy, and that is that as soon as you start bringing in a large language model to help you build the knowledge graph, you're losing some of the reliability that the knowledge graph had. And so that's what our proposal is around. We're thinking about how can users manage the synergized large language model plus knowledge graph system. In this proposal, the user is adding new information, verifying inferences, editing information and organization, and providing feedback to the large language model. In return, the user is getting the ability to retrieve information and browse information. And we've operationalized this idea in a system called Yodi that organizes unstructured information. It's designed around this concept of a lens you can think of as a portal into one specific part of a large knowledge graph that is often related to a project or a long-term interest or idea. These lenses are portable and shareable. And so what people can do with these lenses is as they put in unstructured information, say in the format of text, PDF, spreadsheets, Yodi can organize that. You can zoom in and zoom out and look at the information at different levels of granularity, so see the overall structure of it versus what's actually in it. And you can ask and get answers based on your data using the large language model. The key design insight here is that large language models are flexible but unpredictable. Knowledge graphs are sort of the opposite. They're predictable but static. And how can users guide the creation of reliable large language model and knowledge graph systems? And we are looking for early testers of Yodi. So if you want to follow this link, and I'll bring it up again in a second, we would love to have you test it and get feedback. So the core idea or core question that I talked about today is, how can we design human-AI interactions that guide reliable use of these models? I talked about helping users craft good inputs to models, helping them evaluate the output of models, and also how users can guide synthesis of these models. Thank you so much for listening, and I look forward to questions.
All right. We have plenty of time for questions. Don't be shy. Well, while you're thinking, I was thinking about the use case of the doctor and the patient and the translation, and I was hoping to get your thoughts on the fact that, you know, if I was to be given something that seemed surprising to me as a patient, you know, like, oh, stop taking your medication, it would probably be more of an interactive discussion, you know, via Google Translate. Do you think, as opposed to sort of a one-off, you know, take this and follow these instructions, do you think that kind of would change a bit how you view the conclusions of this experiment or of this kind of scenario?
Yeah, that's a great question. So the question is, if there's something really important that we need to tell you, wouldn't we just tell you in person? Yes and no.
But also, like the patient would also like kind of have an opportunity to reply.
Yes, yes. So the kind of text that we looked at and the kind of text that was actually evaluated in the slides that I showed was all discharge instructions. So those are the instructions that you get sent home with, and almost always they're all in English, and they have pretty important information in them. So there's one study that our collaborators at UCSF did that showed that on all metrics of post-discharge instructions. So did you follow your medications? Did you go back if any of the things that they said you should go back for happened? Did you have worse symptoms? And all of those, if you're a non-English speaker, you're doing worse than if you were an English speaker. And part of that is because there was really important information in the text that you got sent home with that you just maybe couldn't read. So yes, for a lot of it, it is happening in person and the patient does have an opportunity to respond, but there are places where there's really important information people are being sent home with, or they receive in a message from their doctor that they maybe don't understand.
Okay, makes sense. All right.
Hi, thanks for this great talk. In the user-guided synthesis, when you're talking about distilling knowledge from actual users, how do you validate for the if the user is actually putting truthful information or not? Like if let's say multiple users are interacting with the system, it could be quite possible that 3 people are inputting 3 different informations and one might be true. So how do you handle that?
That's a great question. So the question is, if people are just bringing their own information, how do you know it's true? And that's one of the strengths of knowledge graphs. So you can think about something like Wikipedia, where you can see the background, you can see where information came from, you can see what its source is. The challenge with large language models is that you don't have that. So the thing that makes things trustworthy is being able to trace back to the source. And when we're relying on parametric memory, like in large language models, that's the thing that we miss. And so I think that's one of the core strengths that relying on knowledge graphs has, is that it's sort of like opening up the engine to the car and seeing what is going on, what is the source of this information, and if it's wrong, how can we edit it? And that sort of history and knowing the source is really what makes information reliable. Yeah, exactly. Thank you for the question. Yeah.
Hi, I'm wondering, are there any numbers from Google itself for the translation on the medical conversation between patient and doctor on their accuracy? Like, why Google translation been used in the medical scenario in the first place? Like, were there number from Google itself or?
That's a great question. I can't speak for Google, but I think that what this tool was designed for and thought, and people think about it, is like you're traveling abroad and you want to order a pizza or something. And so, but it is being used in these medical settings. And our research showed that a lot of the times the hospitals were just kind of pretending it wasn't or not really saying anything about it, and that's a big problem. The physicians and clinicians were using it a lot, even in face-to-face with patients. For instance, when they were in a time crunch, they only had 10 minutes with the patient, they would have to wait 30 minutes for the interpreter to come. And so because they used Google Translate a lot in their day-to-day, they would just rely on it for this specific use case. So I think that we need a lot more work to be done to figure out how are models that were trained for another purpose being repurposed to be used in these high-stakes settings. But again, they are because they're really useful for the patient, for the physician at that moment. A lot of physicians also told us that it was the patients who were bringing in the Google Translate, because if you're not speaking English, you're in an English environment, you're using Google Translate a lot in your day-to-day, and it seems to be working fine. So a lot of the times it was actually the patients that would type something in and hand it to the physicians. And so we're using, another big challenge here is patient confidential information being used on a model that doesn't have HIPAA guarantees. So I think that the first step is to acknowledge that the system is being used in medical settings. The second is probably to develop specialized models for these kinds of settings with the required reliability metrics and everything like that.
And you mentioned that there is already translated data available at the hospitals, right? So was there a to train a model with that data also?
Yeah.
Like,
yeah, so the data isn't enough to train a model. You could probably use it to fine-tune a model. We used it as examples in a nearest neighbor model, but you could probably fine-tune models on that as well, and that will probably really increase your reliability. I think there was one instance where, during COVID, there was a big push to get a lot of the healthcare communication data translated. So that's a big data source as well that could probably be used for this.
okay, thank you.
Thank you first.
Actually, she was.
Thanks for the great talk, Niloufar. I had a question about technology adoption. So if physicians have a system that works significantly better than Google Translate, is that something that if this was, just more readily available, they would just switch out, or are there other barriers that you uncovered in terms of like longer term technology adoption? Thank you.
So a lot of physicians are using systems that the hospital provides, like Epic, and a lot of them were saying things like, I wish that this was just embedded in Epic, because they're having to do a lot of work basically writing their instructions, the ones that are using this for instructions, copy-pasting it into Google Translate, copy-pasting it back into Epic, and then some of them used a paragraph that they had written beforehand, which said something like, this was translated with Google Translate, use with caution, or something like that. So I think we just need a lot more standardization and a lot more education of like best practices. But I think if something like this is available in the tools that they're currently using, I think a lot of physicians would like that. One challenge is that these tools that physicians and clinicians are using right now are pretty outdated, and it's really hard to make changes to them. A lot of them actually started off as billing software, and then people started adding more features into them to be used for taking, say, hospital discharge notes. So I think this is actually an area that there is space to do a lot of improvement, especially with the newer models.
I had a question. So a lot of patients, and from previous experience, both in clinical trials as well as dealing with the relatives, are in altered mental state. So they're stressed, they're tired. Can this system be used to not just improve the accuracy of translation, but comprehension of the translation as a second benchmark?
Yes, I'm glad you asked that question. That's actually work that we're doing right now. So in healthcare communication, there's this concept of patient education, which we're relying a lot on here. So there has been work actually earlier by our collaborators at UCSF where they found that you could train a model to basically detect a patient's medical literacy by their past messages. And just showing a physician their medical literacy score made the physician themselves better at communicating them at their level. But there's a lot that you could do now with these language models and other kinds of models to do that automatically, to answer questions. We have a project that we have right now with UCSF. About 2 to 4% of people in San Francisco have diabetes. It's a very hard condition to manage. There's just a lot that you have to learn about how to manage it. And so we're developing a system where we can answer patient questions about their day-to-day and the things that they're trying to learn automatically, and that's a really, really big reliability thing because our physicians want to have seen every single response and verified it before it goes out to a patient. And so so these are, the reason that I'm picking these problems is that they're at the far end of reliability being really important. But you're completely right that we could do a lot more in helping people understand their condition, understand their instructions, coming to their level of the language or other aspects of their communication and do a lot better in communicating with patients.
All right, we have 2 more questions and then we'll go for the break.
Thank you. Great talk. Regarding for the database that you guys have for the physicians, I was curious to see that. Did you see any biases or variations, for example, for a physician A, that he has to deal with like heart surgeries every day, that he might potentially facing a lot of like life-threatening conditions? And for example, Dr. B, that he's just do typical daily care, fevers, headaches or something that which like is less likely to have those kind of scenarios. Did you see any differences in terms of the judgments that they make for the quality assessments?
That's a great question. So we have one paper that was published in FACT last year where we did a study with a range of different clinical settings. The places that we found were using, especially machine translation, the most was very low resource settings. So clinics across California and more rural areas where maybe they had a harder time even getting an interpreter. So they were using these tools a lot. The people that we worked with to build to follow were in the emergency room. And one of the things that is special about an emergency room is that you have a really wide range of conditions. And so that makes it a little bit harder to be specific to each condition. Some of the people were saying things like, if you're a surgeon, a lot of the times you're doing, say, a kidney surgery, those we have pre-existing translations for. So there's a whole packet for someone who's had a kidney surgery and it's already translated to a lot of languages. You can hand that to the patient versus, say, a setting like an emergency room where it needs to be much more specialized to each individual case.
Hi. So a lot of the examples, or at least the examples in this presentation, were large language models that have a pretty robust data set under them. I know another example of when you have like instructions in person, but then there's follow-up instructions that, are in refugee situations. Specifically, for example, I have a friend who works with trying to find employment for refugees in the United States. And then that's a situation where like, it's actually very easy to find a Spanish translator, but it's a lot harder to find like an indigenous Mayan translator. And then so I'm wondering like, what is the benefit of using a knowledge graph with a large language model when the large language model is very deficit in like indigenous languages, for example?
Yeah, that's a great question. So one of the cool things about retrieval augmentation is that you need a lot less data for it to work well. And so especially for cases where you have low data sources or low resource languages, for instance, with Sofalo, I said that sometimes we just find an exact match in the translation memory. We tested this with emergency room discharge instructions, and that happens for somewhere between 35 to 60% of sentences. We have the exact match, and so we only need one sentence. We, of course, take out the entity words and put them back in, but we only need one sentence translated once, and we can, translate 30% at least of the text without needing a whole lot of training data. And so I think that's one of the things that retrieval augmentation is actually going to be really good at. The other example is that one of the things that's really, really hard in medical communication is topics that are taboo, because it's really different how people in different languages speak about them. So you can think about sexual diseases or things like that. And so that's one of the things where I think it makes a lot more sense to just have instructions somewhere that you can retrieve at that point versus like wanting to go and gather a whole lot of data about a specific taboo topic and how it's spoken about and train a model. And so, yeah, I think in those kinds of situations where something's really, there's low data on it, or it's just really hard to gather data around it, retrieval augmentation can be a huge plus.
Let's thank Dr. Salehi again.
Thank you so much.